Welcome back to Plenary Session and the Drug Development Letter. I'm joined by my friend and colleague, Dr. Timothy Olivier from Geneva, Switzerland. It's good to see you, Timothy. It's good to see
Hi,
you.
Vinay. How are you doing?
I'm doing well. I was recently in ASCO, and I was giving a couple of lectures, and throughout the lectures, people came up to me afterward and they said, "Where's Timothy? We need Timothy here." So,
Yeah,
back by popular demand, here you are.
I would have been glad to join. Actually, I was in Chicago in the mountains in Switzerland, so this was also interesting. But I would have enjoyed to be there with you and everybody.
The closest things. Chicago in the mountains. All right, we're here with the special post ASCO edition. Let's go to the next slide. And we're going to talk about several of the abstracts and presentations that we thought were most interesting. Laura, we covered this in the pregame session. We're going to revisit it now. Crown, which was an interesting, the first time you've ever seen anything like it. That's what some people say. Nadina, Checkmate 9, DW, Transmet, and Post Monarch. So let's get started. Let's get into Laura. Laura's, of course, the randomized controlled trial of stage 3B non-small cell lung cancer, people with EGFR mutation positive, who are getting osimertinib versus placebo after concurrent or sequential chemo RT. So, Timothy, what do you think? What did we
Yeah,
what did we see here that we didn't talk about? Yeah.
so actually, I mean, we knew that there should be a standing ovation. I don't know if it was as successful as it was, I think, 1 or 2 years ago, but this was the plenary session.
So I should say one thing about the standing ovation, that somebody told me from the drug companies that they actually put a lot of their own people in there, and they actually try to start the standing ovation themselves because they all want that standing ovation, which is just part of more of the bullshit pageantry of this ridiculous conference that really, in my opinion, works primarily for pharmaceutical interests. All right, next slide. Let's get into it. What are the problems?
Yeah,
Here's the key figure.
Yeah, here's the key figure. So there's a huge BFS benefit. You see the median, almost 40 months with osimertinib, roughly 6 months with placebo. So, I mean, this were the moment where there was a standing ovation.
And you know what? One thing I didn't notice until now. This is the BICR review. Do we have the investigator assessed PFS curves?
I'm not sure. I have to double check.
I haven't seen that. All right, we'll have to look at that later. All right, let's see what else we got.
Basically, what I did, I just took the points we made before and just go through them. So these are the points we made before, and just to go to the first point. So
proper staging.
Yeah. So
they didn't do it. They didn't do it.
So basically, this number, half of patients had no PET-CT. It's not really a number that we could find. This is a number that was told. It was on social media. It wasn't contradicted. So I think it must be true, but it's not in the paper. It's not really an official number, but I think it's pretty close to the reality. So
let's
do you want to comment on that?
Yeah. Why is this stupid? Okay, so they're running this in countries that don't have access to universal PET-CT for stage 3 disease. That's crazy, by the way. It is the standard of care in the United States. It's in NCCN guidelines. We do PET-CT. Why do we do PET-CT? Because if you're high enough risk to be at least stage 3, you might even be stage 4 disease. You might have some occult adrenal mets. You might have some mets in the bone. You might have some mets elsewhere in the body. The best way to detect those metastatic sites is PET-CT. We're doing this to find people who we think are stage 3, but actually stage 4. Now, they didn't do that for half the people in this trial, which means there's probably some people in this study who have stage 4 disease. It would be interesting to know, in the half of people who got PET-CT, how many of them were upstaged as a result. They don't report that either, but that will be a clue how many people with occult disease are in there. Why does that matter? We already know osimertinib has a benefit in people with metastatic disease. We're not trying to prove that. We're trying to ask if the routine use in stage 3 is preferable to the current standard of care to monitor people with stage 3 and reserve osimertinib for the few people with stage 4. They're seeding this study with occult metastatic disease. This is terrible. Finally, they're going to say, well, these places can't afford a PET-CT machine. Well, if you can't afford a PET-CT machine, you know what you sure as hell can't afford is a couple of years of osimertinib, because that's far more costly than a PET-CT.
Yeah, and to make your point, I mean, I think this is the first time ever that the trial designed with osimertinib forever. It's osimertinib forever. There is no end date. It's until progression or toxicity. I mean, yeah.
That's an interesting point, yeah.
The second point, I was interested of what was the rate of patient not progressing in the control arm. I think it's related to the first point also. And I did a kind of cross-trial comparison because we had already the data from Pacific, where we knew for EGFR mutant patients that in Pacific they were doing not so well with durvalumab. Durvalumab was not adding something, but when you compare those curves, I mean, it's cross-trial comparison. It's not, very strong data, but really we see that the placebo arm in LAURA is really, really bad in a sense. Patients are progressing so fast, and I think this is most probably a sign of occult metastasis or downstage patients.
Yeah. But it's interesting. I wonder in Pacific, they also didn't do universal PET CTs in Pacific, I don't think.
Yeah, I don't think so.
Yeah. But what this tells you is the fact LAURA is underperforming even historical benchmark Pacific. You should take it with a grain of salt, obviously. But one concerning implication is that there's a lot of occult disease in this study. All right, go on.
Rate of crossover. So here we have the data, and I just want to point out, maybe I will go through this slide. So this is reported. This looks pretty high in a sense, but there is a thing, it's often the case. It's not reported how many patients get any systemic treatment upon progression, and I think it would be important. We are not sure it's systemic treatment. Why it's important? Because, just for the sake of reliability, these are not the same number in the paper and the supplement. In the paper, it's 50 patients. In the supplement, it's 51. So I would really like to know if it's 50 or 51 or what happened here. But to come back to the point of systemic therapy, I think there's no reason, not a single reason, why a patient should progress and receive another treatment than osimertinib. But they say it's 80%, 75%. We don't know the rate of patient with systemic therapy. And so, this would be an interesting piece of data. And this also really illustrates how complicated it is to interpret those data when we have them, and they're often
There's one more point here. Okay. Look at the numbers that they're saying. Okay, 57 people got any subsequent anti-cancer treatment. 57, that's what they're saying. 57. 51 of those people got osimertinib. So that leaves 6 other people, right? But wait a second. First or second generation TKI is 7. VEGF inhibitor is 5. Cytotoxic is 11. 7 is platinum-based theriamucil. This is not the next initial therapy. This is a sum of all the subsequent therapies. Okay? So what this means is some of these people are not getting FLAURA, standard of care. Some of these people are getting osimertinib in the second relapse metastatic disease, second progression. That is absolutely unacceptable. First of all, 80% is not good. I love how the discussant's like, 80% crossover. That's great. So 20% of people deserve to die? So 20% of people should just die without osimertinib. That's your ethical standard. It's okay to let 20% of people die without the drug. Next point, they're not getting it at first progression. Where is that data? Why do they not provide line-by-line data? Absolutely disgraceful. And the discrepancy, 50-51, that just shows that all of these authors, so many authors, and nobody can find this discrepancy because these authors are not reading the papers that they're on. Many of them are just added as token authors. All right, those are my points.
This 66 number in the upper panel, it's also not the number of progression. It's patient that I double check that. So is this really, illustrate how difficult it is to interpret those data when they are not complete and reported like that? Yeah.
Timothy, let's write a letter to the editor for this paper and let's ask for the first immediate prior therapy. That's what we want to know. All right, let's put that together. That's easy to do. Okay. Break down the PFS.
I think we have to ask the number of patients that receive any systemic treatment. It's not reported, and the question you ask, and maybe the question of PET-CT, because it's an important question. Breakdown of PFS, it's partly reported in the sense they are making the difference between localized recurrence or distant recurrence, but it's not really clearly reported. And we were waiting for the risk of developing post-radiotherapy pneumonitis, and this is higher in the osimertinib group. So as you can see here, I don't know. What is your, takeaway message? Or of course, this is to me something to discuss with patients. But again, I think this is really a discussion to have with patients. because in a sense, the only way not to receive osimertinib continuously is to choose the strategy of being followed very closely. So I think this is a real place for shared decision making. I don't know what you think.
Yeah, I mean, obviously, shared decision making. I think to me, this is a much more potentially beneficial place than stage 1B, for instance. 1B, like ADORA, and ADORA is a much worse study. But this is still a shitty study. That's one point. Second point I want to talk about, let's talk about budgetary impact. Okay, the number of stage 3 patients, 3A, 3B, who are EGFR mutant positive, who are going to be placed on this drug, who otherwise wouldn't get it very soon, is very small. I mean, the budgetary impact, AstraZeneca, they can pop all the champagne bottles you want, but in terms of actual dollar bills, they're not going to get that many dollar bills from this intervention. So even if you gave it to everyone, it's not going to have a big budgetary impact. That's my point. But another point is that there is an article in Stat that says AstraZeneca's goal is $60 billion a year in revenue from from cancer drugs, and they're well on the way to the goal. This is the problem. The goal should be to run clinical studies that are actually informative. I still don't know. Honestly, I still don't know if it's better to give these people with the concomitant risk of radiation pneumonitis osimertinib after chemo-RT, or to give them a treatment holiday and reserve it for when they relapse. I still don't know. They're not running the correct study. Bad staging, bad event. But I think if any place is going to show a benefit, it's going to be here more than,
Yeah, absolutely. I think in all fairness, I think there is a high risk of recurrence, and this you should tell it to patient. But even this thing about CNS and brain metastasis recurrence, sometimes they are asymptomatic. Sometimes you can find them on the MRI, and
sometimes you can gamma knife them and still hold osimertinib in your back pocket.
Yeah, so I think it's really where you should discuss the results. Of course, this has to be discussed with patient as soon as this will be available. But
one last point is, once you progress on osimertinib, which you will progress, because go back to the PFS curve, the people on osimertinib are progressing, right? Look at the Look, they're all eventually going to progress. That's the other thing they're missing. Okay, it's not curing anyone. All right, they're all eventually going to progress. When you progress on osimertinib, guess what? You don't have access to any other TKI. It's all off the table. You're going to get chemo, platinum-based chemotherapy, and then you're going to get docetaxel, ramucirumab. Oh, except when you found a clinical study, then no ramucirumab for you. And then you're going to die. There's no other drug. You can't get checkpoint inhibitors, et cetera, et cetera.
To me, the main point is that there's a fraction of these patients that are cured. It's a small fraction, but if you really
I thought so too, but what undermines that argument is that the placebo curve almost touches,
I mean, it depends of your staging, but I don't know.
That could be the staging, but that undermines the argument that there's some people cured in there. It looks like, I don't know, unfortunately no one's getting cured, but I do think that you can cure some 3 patients, of course. Okay, let's go to the next one.
So the next one, is a new study, so Crown, and maybe you want to describe the study briefly, or?
I mean, I know of a study, it's called ALEX, and I read that study maybe about 5-6 years ago, and ALEX is a randomized controlled trial of alectinib versus crizotinib, which was the first drug in class. ALEX is a randomized controlled trial that showed alectinib had a superior PFS and later superior overall survival than crizotinib. Now, many years later, many years later, after everybody I know and all their friends are giving alectinib, we get Crown, a randomized global phase 3 study of lorlatinib, which is a very toxic drug, probably, in my opinion, more toxic than alectinib, versus crizotinib, which is a study that I know the answer to because I knew the answer 5-6 years ago. All right, what do you got?
So is the Crown deserved, and is lorlatinib the new standard of care versus alectinib? You describe exactly the point. And to be honest, we already had PFS results from Crown. So Crown is, I was a bit surprised it was so, a big thing in ASCO, because we already knew that the PFS curve were better than ALEX, and this was, I think, 2 or 3 years ago. But this is the main results. So PFS benefit, and I think everybody was commenting on the curve that the median is not reached and this kind of thing. As you said, I think this is the main point. I mean, to know if lorlatinib is better than alectinib, you could have run the trial, because these are the dates, and alectinib was approved in
But for the audio
17,
listeners, let's say, so he's showing a figure that shows alectinib was FDA approved in 2017 based on the Peters study, New England Journal, that shows clearly alectinib has this benefit over crizotinib. Then he's showing lorlatinib study began accrual in 2017 after they knew the results of the alectinib study. They may say that they started slightly before they had those results in hand. Okay, but then what's the reason why you continued to accrue for year after year after year against a substandard and flawed control arm?
Yeah, and also you are not enrolling all the patients, at the beginning. I mean, that's,
correct. You may have enrolled 10 people before you had that data. And also they knew the data because that data had been released, but whatever. Yeah. And I bet I haven't checked for overlapping authors. I bet there's overlapping authors.
Yeah, I checked quickly. I couldn't find, but I'm sure I think
Fair enough.
maybe if we take a deep dive, maybe.
One last thing, I saw somebody say that we're turning ALK rearranged lung cancer into CML. I'm sorry, you have to be kicked in your head to think you're doing that. Okay, the median survival for ALK rearranged lung cancer is at best 7 years. For a 50-year-old woman who was diagnosed with ALK rearranged lung cancer, the median survival that woman would experience in the absence of that diagnosis is about 27 years. That's a 20 years of life lost gap. Imatinib closes that gap entirely. If a 50-year-old woman gets diagnosed with CML, she has a 27-year life expectancy on imatinib. So, I mean, come on. Don't be so dishonest to say that this is like imatinib. It's nothing at all like imatinib. The glass is mostly empty. It's both dishonesty, ignorance, hyping, and then the person saying this is consulting for the pharmaceutical company. I mean, what am I to? That really strikes me as just unbelievable.
Yeah, I think this is I mean, and you put these curves just to put that in context, and you can really see that these are not the same curve at all. Yeah. The next slide is the toxicity you talk about, and it was presented, and it was very small on the slide, but you have the CNS adverse events in 42% of patients. So I just put a kind of zoom. What is this B appendix? And I just zoom on this, but you have cognitive effects, you have mood effects, you have speech effects, you have psychotic effects, and so there's many other issues with also drug-drug interaction. So this is not an easy drug to prescribe. I think mostly everyone in the field say it's more complicated to prescribe than alectinib. So I think my main point is the suboptimal control arm. To come back to the ALEX trial, I think one point was important. In ALEX, there were 40% of brain mets baseline. It was 25% in Crohn's. So when you are just comparing the curve, I think it's really not possible. It was not the same enrollment period. It was not the same patient characteristics, and the neurotoxicity I think is an issue, plus the financial toxicity. I just double check, and lorlatinib is more expensive than alectinib.
Yeah, just like one point. You've made 2 cross-trial comparisons, okay, and I think to be consistent, we should say the right answer. The right answer is that one cannot conclude that lorlatinib is better than alectinib, just as one cannot conclude that the control arm of Laura underperformed.
Yeah.
You can't conclude either.
I agree.
And I think that's the correct interpretation. There are other reasons why you would worry that there's seeding of occult metastatic disease in that study, and here I just think that there's no way they're going to get the market share. I mean, alectinib's a better drug, and the
last point maybe also it's because after lorlatinib, the next treatment is chemotherapy, and it's not the same with alectinib.
Yeah, whereas alectinib you have other options. Okay, that's fair. Yeah. Next one.
So NADINA. Ipi-Nivo first stage resectable melanoma. So this was
everyone liked this study.
Yeah. So I think there are interesting points. Briefly, the design. I don't know if you want to summarize the design again based on this slide.
Neoadjuvant. You get Ipi-Nivo. If you have CR, you're done. If you don't have CR, then you get a lot of stuff. You get what? You either get more Nivo if you're BRAF wild type, or you get Dab-Tram if you're BRAF mutant. And if you didn't get neoadjuvant Ipi-Nivo, then you just get adjuvant Nivo.
Perfect. So I think this is an interesting slide, and one of the main findings is that 57% of patients in the neoadjuvant treatment had a response that made them get no further therapy. So I think this is a really interesting point. and it's a big number, 57. But we'll come back to that maybe. But I think this was a really important number to show.
That's better than I thought. Yeah.
Yeah, and the primary endpoint, event-free survival, is. Do you want to comment? But it's a positive trial. Yeah,
it's positive. Yeah, it's interesting that how they're handling the censoring, which is massive.
Yeah,
we'll talk about. Yeah,
we'll talk about that. So these were the points we wanted to talk about. So how many patients could not undergo surgery, and what were the reasons? Toxicity, disease progression. We know that these are the usual question we have. And when you go in this patient diagram flow chart, you can see that 7% of patients actually did not undergo surgery. Some had toxicity, some had progression, but it's not nothing. You are randomized between neoadjuvant and adjuvant, and by doing the neoadjuvant strategy, you won't perform the surgery. Of course, the question is it affecting your outcome? Maybe you would have the surgery and maybe you would have the recurrence after. So it's not a definitive answer, but 7% is not nothing. I don't know. What is your comment about that?
Did they show OS data? No OS data.
No OS data, no.
And then the other question I have is, what happens if you just do neoadjuvant Nivo alone? How do I know what the IPI is adding?
So you remember, I mean, we don't have the answer. We don't have trial. We have the SWOG 1801 that was neoadjuvant surgery then Nivo versus Nivo alone, and we published a paper about that because there were a strange rule about the time biases. I mean, they were affecting the event time to 84 days, and you remember this paper.
Yeah.
But we don't actually, it's in a part of this trial, this is the first trial really comparing a neoadjuvant alone versus adjuvant alone strategy, but only in patients that will not receive the adjuvant part.
Yeah, and then what if the PDL1 is over 1%?
Yeah, this is another question. Of course. I'll come back to your paper.
Go on.
Are early censoring rates balanced between arms? This was a question we had before, and I think this is a very, very relevant question because you can see there is massive early censoring really early on. And to be honest, they made a couple of things that
you have to say for the audio listeners, it's 33% in the neoadjuvant arm and 27%. Yeah, some people will not see the video. 27% in the adjuvant arm. It's about a third of people are censored at the first time point.
Yeah. So to be honest, when you go to the supplementary appendix, they did a few analyses that are pretty good. They did a reverse Kaplan-Meier analysis. They also did a competitive risk analysis. They are just mentioning it in the manuscript. They are not describing it, but it seems they have handled the potential for informative censoring. My issue is when you have such rate of censoring and very different strategies, I think it's very difficult to rule out informative censoring. And to be honest, my question is why the data are published so early? Because why there is so much censoring is just because the data cutoff were very close after we will talk about that later. But I think the data are still immature in a sense.
Yeah.
The question we had, is it a de-escalation trial and long-term data on toxicity? And to me, it's not really a de-escalation trial. It's a de-escalation. It would be a de-escalation trial if there would be less toxicity. But as you can see, there is more toxicity in the neoadjuvant arm, 30% grade 3 or more in the neoadjuvant strategy, 50% in the adjuvant strategy. So it's not a de-escalation trial. Something is missing to me in the paper is what was the toxicity in the group that did not receive any adjuvant treatment. You see? Mm-hmm. They are not doing this detailed analysis, and I think this is missing.
Yeah, that's interesting. I mean, the fact that the neoadjuvant has more toxicity means that it's not a de-escalation.
I think it's just because of the EP component. I mean, we know that, and even if it was not high dose of EP, we can see that it's adding toxicity.
Well, I'm so biased, as you know. Who should get Ipi-Nivo? I know Mark O'Donnell and I have that post where we have some carve-outs at the end, but somebody needs to show me which population on planet Earth has a better OS or quality of life from Ipi-Nivo versus Nivo followed by Ipi, followed by, that's never been shown. In the
There's no
metastatic
trial.
setting, in the
No phase
trial.
3 trial.
No one has ever shown.
I mean, the only one, it was not designed to be compared is melanoma checkmate 067, but it was not designed to be compared. I mean,
and the OS is still negative. The Nivo Ipi is not better than the Nivo only arm, which it doesn't have the power to do, but it's still negative.
Subsequent treatment and
and the only person who benefits from Nivo Ipi is BMS. They got their ass handed to them by Merck. Pembro is crushing, and the only way they can stay relevant with Nivo is adding that Ipi. So that's why they're doing it.
I mean, I think that there may places where even me, I could consider it, of course, and also with the lower dose of Ipi in other settings, renal cancer. I mean, yeah, but even in renal cancer, it was not compared to Nivo alone. It was compared
and what about uveal melanoma,
sunitinib.
for instance? You consider it, But I mean, strictly speaking, that to my knowledge, we have 0 phase 3 randomized studies in melanoma that have ever shown better OS or quality of life with Nivo Ipi versus Nivo. 0, all settings.
In no cancer.
Oh, actually, in no cancer.
In no
Never
cancer.
in any cancer. Not in
because
any
even
cancer.
in renal, it's compared to sunitinib.
Yeah, I mean, even in renal.
Yeah. It's not compared to Nivo alone or Pembro alone.
That's right.
And this is the last point that it's really there's really why such a rush? To me, data are not mature enough, and I don't really understand. I think it was a cooperative trial. I don't see why there is such a rush. And also Christian Blanc in the conclusion said very bold claims. He said, This is a new standard of care. All protocol in the neoadjuvant or adjuvant setting should be amended to implement the NADINA strategy. I think it's a very, very bold claim. The strategy is more toxic, 30% grade 3-4 events versus 15%. So, I don't understand really this rush and These are
no standing ovation. Okay, next trial.
Okay. So next trial, this is a new one we didn't talk about before. So it's Ipi-Nivo high dose, same doses as in the checkmate 067 trial in melanoma versus lenvatinib or sorafenib in first-line metastatic or advanced hepatocellular carcinoma.
Where's the Tezo-Bev arm?
Yeah, this is a very good question.
Okay, where is
I keep it? I keep it for the last point, but you're absolutely right. This is the main results. Overall survival.
Is that positive?
Yeah,
that's
it's
positive.
I know the curves are crossing, but it's positive.
Oh wow, the curves are crossing. Proportional hazards is not met. The p-value is from what, log rank? Yeah, stratified log rank. 0.018. Okay, so what do I see here? I see that it looks like Nivo Ipi losing in the beginning. People are dying because obviously there's a bunch of people with HCC who not responsive Nivo Ipi. They're dying, sad. Then it starts to pull ahead after a year, and then by 24 months there's like a slight increase in 24-month survival, and then maybe a 10% increase by 3 years. But look at the tail of the curve. I mean. It looks like a fairy tale, not a tale. It looks like that, I'm not sure there's going to be a cure.
Yeah, there's not many patients here. And so on the right, I put what do these results mean according to the investigators. So they say that Nivo Ipi may be a new initial treatment for people with unresectable liver cancer, helping them live longer. So question mark. So let's go through 4 points. Okay?
4 points, okay.
Yeah. So the first point I want to make is really about patient selection. Because the sorafenib median overall survival in this trial is 20.6 months. So, people say, okay, we have better treatment, better second-line treatment. But in Himalaya, it was 13.8 months. In IMbrave 150, so Atezo-Bev, it was 13.2 months. In SHARP, as you know, it was 11 months. And in real-life settings, this paper we often cite here, that's in a paper, medical beneficiaries, it was 3 months.
This is such a good figure. He's showing a figure of all the trials and showing that the sorafenib median OS is really much better. It's double what it was in SHARP. And also, are you going to show the duration of treatment?
No, duration treatment. I don't have the data. I looked at that. I don't have the data for Checkmate. It was not published yet.
The point I would want to make is it's probably double the median OS with half the treatment, because in Sharp they got 5+ months. In IMbrave they got like 3 months. They got half the treatment in IMbrave, and I don't know how much they're getting of sorafenib here. So it is a lot of cherry picking the healthy HCC patients. That's your point.
So some people may say better supportive care, better second line therapy, but I think it's not really that point.
If that were true, then the Stacy Ducizina wouldn't be 3 months. That would be like 15 months.
And even though if we take more recent trial, Himalaya and IMbrave 150, the difference is so big with those.
Fast,
So what is more likely? I think is worsening the efficacy effectiveness gap, and this is to me my main issue. These are not representative of our patients. The second issue I have is the toxicity. So grade 3, 4 treatment-related adverse events, 41%. Treatment-related deaths, 4%. And I would be very cautious, because these are lower than we saw with melanoma with long-term data. So I think it could be
4% treatment-related deaths in this healthy population. That's not nothing.
And also, it's treatment-related deaths, and we know that. I mean, as investigator, we know that sometimes, I think it's better to have treatment emergent deaths and to really compare those between arms.
Yeah, that's interesting. Okay, next one.
I go to the third point. Subsequent anti-cancer therapy, 56% of them. So I think in highly selected patients, this is very low fraction of patients receiving any subsequent therapy. And
whoa, wait, hold on. That's fascinating. So they're living 20 months, they're getting a whiff of sorafenib, and then they're getting nothing afterwards. It's insane. That's insane. That's really
It's really impressive.
It's really impressive.
Last point, I will go fast. But
the quality of life is shitty.
Remember, we did this, I think it was our first project together, but we did a reanalysis of the Checkmate 067 trial. And basically, when people are not when they are suffering from toxicity, they may be less likely to fill out their quality of life questionnaires, and so the missing data can be massive. And so I really want to see this data published to see that.
Good.
Maybe you can explain it again. Okay.
No,
so these are the points, and the first point, as you said, the control arm is suboptimal. Again, the trial started to accrue.
The trial started accrual in September 2019, and atezo-bev was May 2020.
Yeah.
So all the accrual after that date. Yeah. I don't know.
Okay.
I'd rather, I'm not a huge atezo-bev fan, but I think that's better than this. Nivo-Ipi is a disaster.
Yeah.
1 in 20 people are dead because of the Nivo-Ipi. That's what they admit to. It's probably even higher.
Do you want to conclude on this one?
No, I think we're done with this. Let's go next one. So okay, Transmet. Yes.
I will go fast because I had just one point to make. So maybe just a quick summary of the trial. So maybe you can just make a quick summary.
People with unresectable liver metastasis, colorectal cancer, randomized to liver transplant plus chemo versus chemo. Liver transplants obviously are cheap and easy to do. No, that's an extremely scarce resource. Liver transplant versus chemo, and they have like a huge OS benefit. Yeah, right?
And I think
40% difference.
Yeah, I think that's the main point. This is the statistical design. So you see a 40% difference in 5-year OS, 50% against 10%, and then you have the results that is really, the same as the initial assumption. And so our question before, this was the point we were looking for.
Yeah.
We should really be cautious about the statistical plan. Was it changed? And so here I want just to make a comment because I was in this meeting.
Changed.
So and Professor Adam, that was presenting in the ASCO meeting, was also presenting in our meeting in Swiss. He was connecting by Zoom, and I asked him the question about the statistical analysis. And he said that after 29 events, there were an amendment and the statistical plan was changed. So we have to wait for the publication, but
that's
what we
didn't we predict that? That.
This is a slide of before ASCO. This is so maybe these are. We will see in the publication, but I think when you have
And let's explain to the listener why that matters. This is the Texas sharpshooter fallacy, which is that, look, if you have a bullseye on the side of a barn and you shoot at the target, we'll see how good a shot you are. If you get to shoot first and then paint the bullseye, you're gonna hit the bullseye. Okay, you paint the bullseye after you do the shooting. And the problem with statistical plans is they really have to be before. After 29 events, they change it, and the statistical plan and the actual result, P of 0.04, is like almost perfect. It's a perfect hand in glove kind of fit. It felt really weird to me. So
it
was. Go back to the long rank. Why is that long rank so significant? I thought the original p-value was on the cusp. There's only 47 people. All right, well.
So it was very nice. He was here to present, to be honest. I was very thankful, and he really nicely answered my question. So now we have to wait for the publication to understand more what happened here. Yeah. The last trial, if you still here.
Post-Monarch, yeah.
Yeah. So here is a key takeaway from the investigator. I don't know, do you want to read that?
Post-Monarch is the first phase 3 randomized placebo-controlled study to show a benefit of continued CDK4/6 inhibition with abemaciclib fulvestrant following progression on a CDK4/6 inhibitor. In other words, they're just trying to get some more market share in the post-Palbo, post-Ribo world. And it's abemaciclib fulvestrant versus placebo fulvestrant for people who progressed on prior CDK4/6 inhibitor, which could have been in the adjuvant setting. All right.
So really interesting. The primary endpoint is investigator assessed PFS, and this is the main result. So as you can see, plus 0.7 months in median PFS. So they are, showing the hazard ratio that maybe you can just comment on the hazard ratio. Everybody is commenting on the hazard ratio, but it's not a metric that is easy to handle. Maybe you can comment on that because
it's the ratio of the instantaneous hazard rate at all points in time. It's not the same as, if you look at it, the hazard ratio is 0.73, and I hear some people say that's a 27% reduction in the risk of developing a PS event. Yeah, it's written on that slide. Well, that's incorrect. Like the way you need to do that is to provide a relative risk at a time point. Say you're 12% less likely to experience it at 12 months, etc. The other thing is, if you just look at the curves, it's pathetic. The curves have some small separation at the first time point, and then they are parallel to each other. It's a pretty pathetic result.
So, So next slide, you will really like it. So
the blind assessment.
When you go to
huge,
so as a reminder, 0.7 months benefit for the median PFS in the investigator assessed PFS, and when you do blind independent review, you have 7.3 months median PFS benefit. So how is it possible, Vinay? What do you think?
Oh, there's easy. It's censoring. So the only way that's possible is if there are people included in the investigator assessed PFS that do way worse than when they're excluded by the BICR. So probably the BICR has way more censoring. Okay, I see on your slide you've shown that.
Yeah,
the BICR has maybe 12% more.
The curve in both, both curve, and these are the results. So you can see that much more censoring in both arms.
And those censored people are the ones who are doing badly. They're the ones the investigator is saying they progressed, but they're just short of progression.
Yeah. And what is, again, a bit strange, it's only affecting the experimental arm and not the control arm. So this is more likely an issue with the toxicity-driven censoring.
Wait, it's assessing. I thought it's both arms. Look at that. There's 6% and 4%, and then it goes up to 19 and 22.
Yeah,
and 19 and
both
19.
arms. So I think the patients censored were really more likely to experience the event in the experimental arm, and that's why you have this result.
All right, I want to think about that last thing a little more. Interesting.
I just put that as an example, but maybe we go fast or...
No, this is a nice figure from a paper that we did in the European Journal of Cancer where, what's the title of the paper? It says how different PFS rules can create hugely different PFS estimates, something like that.
Yeah.
European Journal of Cancer 2024, using a different trial from lymphoma. Go forward.
No, it was just to illustrate the point that by applying different censoring rules, you can really, distort the result and make very different results. That's what happened. So my main point for post-Monarch are, the primary objective.
Yeah.
It's limited PFS benefit. with such level in censoring in the blind independent review PFS, I think it makes it unreliable.
Yeah.
Those rules not affected the control arm, so likely toxicity-driven informative censoring to my, I mean, that's my feeling, and that's what I think. Because you added a toxic regimen in against placebo, and to me, you're frozen. You're here, yeah. To me, it's even questioning the primary objective because of this difference that we see in the censoring with blind independent review. I think there may be an issue with informative censoring, even with investigator assessed PFS.
Go back to your censoring figure. Okay, so here's how I interpret it. You show on the left, you prove that for investigator assessed PFS, the experimental arm has more censoring than the control arm. For instance, 6% and 4% at the first 2 time points versus 6% and 2%, right?
Yeah. Yeah.
So that to me shows that the investigator-assessed PFS might be plagued by informative censoring where more experimental arm people drop out for toxicity.
Yeah.
Okay. Then you show the BICR-assessed PFS. And here I would argue that it's much more comparable. The experimental 19, but control 18. 22 experimental versus 19. It's way higher than investigator-assessed, but across the arms, it's more comparable. So Why might this happen? Okay, so then my argument would be, what does this tell me? This tells me that investigators are trigger happy to call progression. They are much more likely to call progression than the Central Review Committee. They're basically seeing people on both arms of the study and they're saying, shit, they progressed, even though they didn't. Now, why are they so trigger happy? The only answer is, I think both arms are getting shit. Abemaciclib fulvestrant, shitty. But even fulvestrant alone is shitty. Some of these people need some chemotherapy. Some of these people need some real treatment, right? So the investigator just wants to get them off this fucking trial and get them onto something else. And so I interpret this data. It's a very interesting story. We should write this up. I think there's 2 stories. One is there is toxicity. That's shown on the left. And then on the right, I think you're just saying people want to be off this goddamn study and get the patient on something that's actually working. I think that's what's going on.
But Vinay, you have another clue on the figure. It's written here. You estimate, informative censoring of events where there were higher discordance between events in the abemaciclib arm versus the placebo arm. And to me, this means So I mean, to me, this gives a clue about what censoring was driven by toxicity and not events. You see my point?
Yeah, but actually it's even more interesting than... Okay, I see that print. Wow, so what that means is that even though you're getting way more pulling people off the study sooner with the abemaciclib arm, you still have roughly the same rates of censoring.
Yeah.
This is really a jigsaw puzzle. All right, I want to think about it more.
Yeah.
I think both things are true. Toxicity withdrawal is true, and there's this tendency to just drop people off the study because they got to move on. I think both are going on, but I want to think about it more. All right, let's go to the end.
So, I mean, we reviewed those abstracts. We kept
Laura, Crown, Nadina, Checkmate 9DW,
yeah.
Transmit, Postmarner, good stuff. And what's the takeaway?
So, I don't know. What
takeaway.
is your takeaway? I mean, it's always interesting. We never know what will be, the talk of the town. I was not expecting Crohn to be such a big deal because we already knew that PFS was better than Alex. And on social media, it was really a thing, with many great comments about why it should be the new standard of care in first line. This Epidemiology in the... Yeah. Okay, go on.
My takeaway is that this 40-minute discussion, which was supposed to be a 20-minute discussion, this 40-minute discussion probably has more gems on how to appraise clinical trials than the entire meeting. And I think they're really doing themselves a huge disservice by inviting 66% of the plenary speakers who discussed drug trials who were being paid by the company that also ran the study. They're having a huge disservice by just inviting the usual cheerleaders to the conference. They really need to have some critical appraisal session. I hosted my own session at this ASCO. I'll probably do that at ASH. I think that, in this world of competing places for attention, podcasts and drug development letter and things like that, they're going to make themselves irrelevant if they don't want to have an honest discussion of these products. If they want to make ASCO the pharmaceutical companies convention, which is what it seems like to me, they've done a great job of that. But if they want to make it a scientific conference, they're going to have to actually get some critical appraisal. Those are my thoughts. All right. Your closing thought, and then we'll end it.
No, I think it was very interesting, and it's always great to discuss the data, to see the data. Maybe the last thing, they are releasing the papers before the paper is even presented, and there's so much marketing, so much, and it's a bit it's a bit annoying. I feel, and what I like is really to take the time to appraise the data as we are doing here, and I agree. I think that's what people want. And I was in Chicago in the mountains here in Switzerland, and people were really talking about that in that way. And I think that was really great.
Great topic. All right. Thank you, Timothy. And until next time.
Until next time.